Good evening. This is Tanveer Rab from Emory Cardiology in Atlanta. I'm delighted that we're going to present our first bifurcation hour. We'll do these sessions for an hour once a month. We have an excellent group of people, as you see in the picture, high volume operators. And our goal is to show our cases, learn from others, and really discuss bifurcation techniques. We had an overwhelming response in terms of presentations submitted to us. We're delighted we're going to have Dr. Sunay Shah present his case today. But we'll start off with our bifurcation members, with Dr. Basir presenting a case, with Dr. Meraj being the discussant, and then Dr. Meraj will present a case, and Dr. Basir will be discussant. And finally, we'll have Dr. Sunay present, Sunay Shah present, with Dr. Basir, Dr. Meraj being the discussant. I'll moderate and intercede as needed, and we'll try to limit our presentations to less than 20 minutes each. So we get going with Barbara Basir from Henry Ford Hospital, Detroit. He's the Director of Acute Mechanical Surgery Support. And Barbara, lead us on. Thank you.
Thank you so much. I'll get right to it. So I'm going to discuss a step-by-step high-risk DK crush. I'm interested to see what you and the rest of the panel would do in a similar scenario. So I have personal conflicts of interest as listed below. So getting right to the case, so this is an interesting patient. She's 60 years old. She's been having 2 weeks of on and off symptoms and presented to the hospital with an NSTEMI. Her peak troponin, or first troponin, was already 16,000. We use a high sensitivity assay with a maximum of 20,000. She was urgently taken to a cath lab at one of our community-based programs. She had ongoing symptoms. Her heart rates were in the hundreds, blood pressure normotensive 140s over 90s. You can see that her right coronary is occluded. She has a very tight ostium of the circumflex ostial LAD distal left main. You can see kind of a boulder of plaque right at that ostium. You can see it also in a caudal view with pretty robust collateral filling of the RCA. And then the original diagnostic was done via radial, and you can see normal peripheral anatomy that ultimately led to the placement of intra-aortic balloon pump. So the patient came to us, was hemodynamically stable with improvement in her chest pain. She had an EF of 35 to 40%. Her hemoglobin A1C was 10. Her STS gave a mortality risk of around 8.5%, a morbidity and mortality risk of 29%. And she was preliminarily accepted for CABG. And actually, the case came in kind of late on a Friday, and she was boarded for CABG on Sunday. On Saturday, she was getting workup, and on further history, she actually had endovascular venous laser treatments in the past, and this precluded any use of the saphenous vein grafts. She actually then underwent ultrasound of the palmar arches, and they were non-patent, and so she did not have radial conduits, and that left only her mammaries. And with her hemoglobin A1C, our surgical colleagues declined her for surgery. So she is a young patient, surgical turn down. Her EF is 35%. She has a balloon pump in place, but hemodynamically stable. She has a complex bifurcation. Medina 111 would fit the definition 2 criteria for a complex lesion. There's a need for atherectomy or possibly, and she has an RCA CTO. So this is the current case. Just wanted to reach out to the panel and maybe just quickly discuss what we would do in this scenario. Perwaiz?
Yeah, Bobber, it's a great case. Unfortunately, we're seeing more and more of these kinds of cases come on our plate, younger patients with difficult anatomy, low EFs, and really surgical turn-down cases, I think more than we've ever seen before. So I think it's great. I think the first step is, for the audience is, I think that it's very important what you did, stabilize the patient, and then get a surgical opinion to be able to see what the next steps should be. The surgical conversation was good, and then now what do you do? So now that you're faced with performing the PCI, what's the next step? So I think there are a lot of factors here. I think one, assessing the hemodynamics of the patient and where the patient stands, in determining whether or not support is necessary to perform the PCI. What is the strategy of performing the PCI, as you mentioned, and the fact that there's calcium there in terms, looking at the imaging maybe to see intravascular imaging to see, the arc of calcium, the density of calcium, where the calcium is, and what needs to be atherectomized. I think there are all those factors are key in the planning of this case, and I think when you plan this case right, the case will go very well. So, anybody else on the panel want to chime in or comment on proceeding forward?
Well, the thing that concerned me, she doesn't have renal failure, and for a young woman, why does she have so much calcium built up the left main? For distal left main is almost like a rock sitting there.
Yeah, it's interesting. Yeah, I don't know. I think the diabetes had a factor to it. She does not have a significant kidney disease. So, but I completely agree with you, Perwaiz. I think we're going to follow a very similar course of action here as to how we treated the patient. So I thought, I know that we've had over 150 registrants. We've got a lot of interest in the ABC Club, really wanting us to kind of teach bifurcation. So I thought, listen, why don't I just take this case step by step on how I approach it, and then afterward we can discuss with the panel if they would do something differently. So just as Perwaiz mentioned, from my standpoint, this patient starts off with a hemodynamic assessment to see exactly where we are. So we actually treated her medically, for the first 48 hours, and she was pretty optimized. She had a right atrial pressure of 12, a wedge of 17. She, had symptoms for quite some time. Her anterior wall was down on her echocardiogram. She did not have Q waves. Her cardiac index was low at 2.1, and that's with the intra-aortic balloon pump in place. So I did this case with one of my fantastic fellows, Yelena, and I'll be honest with you, we debated back and forth about whether to actually upgrade the support. My original inclination was to do this with just the balloon pump. We know that patients get really reasonable results with the balloon pump, and Protect 2 actually, interestingly enough, did show that. But when she came in to the cath lab, she was a little bit more hypotensive. I felt a little bit more uncomfortable because now she had already waited 48 hours. Her troponins had peaked to over 20,000 while she was waiting for the surgery. And so I elected, because she had no significant peripheral disease either, that we would be able to safely upgrade and use an Impella for hemodynamic support. So in this case, I did not use a radial access because of the fact that she had an incomplete pulmar arch. We used an 8 French 45 centimeter bright tip. Ultimately measured Impella with a Manta for closure. Given her young age, we wanted to minimize any complications, so we used an early bird bleeding detection system as her venous access, and then put a swan through that as well. Ultimately, she was not the largest patient, so we ended up using a little bit less aggressive of a guide. A typical guide is an EBU 375 or a 4.0, but I downsized to a 3.5. You can see that kind of boulder of plaque in the distal left main. The imaging on the angiograms with the guide in place are very similar to the diagnostic. And she had really just beautiful targets, and I just wish potentially she would have gotten surgery given her diabetes and young age. Ultimately, we elected to image for, second. So, I think if you had any decision about whether you needed to atherectomize or not, I would personally have imaged. I didn't think it was going to get past that lesion. And then just angiographically, now that I can see it on my own camera, I'm pretty confident that this is pretty significant calcium. And so I went ahead and I brought down a Xi'an blue. I swapped out with a Mamba microcatheter to a rotafloppy, and I originally started with a 175 burr at 155 to 165 RPMs. So then I did go on to image as my next step. I was able to get into the circumflex with some difficulty. I did have to balloon with a 2.5 to be able to get the IVUS down. And you can see here the IVUS measurements for the distal reference, so around 2.6 millimeters. This was the tightest area. It was pre-treated with a 2.5 balloon, but you can see that the calcium is really kind of 180 degrees. And then you can see actually the left main also has calcium to, just less than 180 degrees. And you can see the break in the calcium here with the rotational atherectomy. So going forward, I ballooned with the 2.5 Wolverine to basically cut the plaque and make sure that I got good expansion, and I was able to achieve that. Then I went in and used the Synergy 2.5 by 28 drug-eluting stent. I had about 3 millimeters or so of the stent protruding into the left main. And then basically did some proximal optimization. Now, in this case, I just used the stent balloon and went up to 22 atmospheres, but I'll be honest, most of the time I'll switch out for an NC and try to optimize that stent with the NC before doing anything else. So ultimately then my next step was to do some form of imaging. I think if I didn't have the contrast room, I would have IVUSed that as the first step. But I felt pretty confident with this picture that I got a good result from that. And so then ultimately I went on to take this picture, then I IVUSed the circ, make sure the stent was optimized, and then I went on to basically crushing the stent. So I crushed the stent with a 3.5 by 8 millimeter NC balloon, and then went ahead and imaged the rest of the LAD as well. And you can see here that the distal reference of the LAD is right around 3 millimeters. And then what I think is important here is, I crushed with a 3.5, and you can see here the 2 layers of stent basically crushed together in the circumflex. And then I went back and I kind of optimized this a little bit more and ballooned it with a 4 millimeter balloon. So after that time, I went on to rewiring. And I think it's important to understand here that we really want to try to rewire within that proximal strut to be able to get, a really good result from our DK crush. So we were able to do that. We went to a caudal view to make sure that we were able to kind of get there. You can see the wire go down. And then, I thought it's always important here to, not just show, everything going smoothly. So, typically what I do is I will anchor into the LAD and just bring in the NC right away. But I was not able to pass an NC balloon. And so then ultimately what I ended up doing was ballooning with a 2 millimeter balloon, and then kind of going back with the 3.0 and optimizing the stent and the ostium of the circumflex a little bit more with, very reasonable expansion. So at this point, I turned back to the LAD and tried to optimize that a little bit more. I used the 3.5 NC. Having already done the atherectomy, I didn't feel that a cutting balloon was necessary after that imaging. And again, I bring the stents, the balloons back to do my first kiss. I start with the side branch and balloon to high pressure, and then I balloon the main vessel to high pressure, and then I did the first kissing inflations, both to 12 atmospheres there. So by that time, the LAD has already been optimized. So I used the 1-to-1 sizing with my distal reference, put a 3.0 by 32 Synergy into the left main and to the LAD, and basically went on to perform my first pot, which was with a 4.0 by 8 NC balloon. After that first pot, then again, we're rewiring into the ostium of the circumflex, which did take a little bit of time. And I think it's just natural that you're going through 2 layers of stent, that sometimes it takes a little bit of time. Sometimes you have to be really meticulous. You have to potentially use a microcatheter, but really it's a critical step. So it's important to try to get to the right spot. And then again, I personally didn't even try with the NC balloon just because of this angle. I went directly with the 2.0 balloon to optimize it. And then what I like to do is I like to kind of confirm that that balloon is gonna, go back in when I put the NC in. So you can see here me going back and forth with the 2.0 balloon and making sure that it passes easily through that bend. So after that, I went back and did my second kissing balloon inflation with a 3.5 in the LAD and a 3.0 in the circumflex, and then did another pot with a 4.0 by 8 millimeter NC balloon. And so what you can see here is that after that point, I went back to image the LAD. You can see the distal LAD has really reasonable expansion of the stent. The ostial LAD here also has good expansion, and you can see here the circumflex. And then the distal left, the middle of the left main here also looks very reasonable. And so I really, have enjoyed working with the ABC Club. And Richard, if you guys remember from the last talk, he said really the goal is to have 2 opposed circles at the end of the bifurcation. And I actually really like that, irregardless of what strategy you're going to use. If you've shown 2 vessels that basically have been well opposed and have a good circle at the end, you think you're going to get a really good result from that. And I don't have any cool 3D models to show, but Richard showed us that his cath lab staff tell him if his head can fit into the coronary on his 3D modeling, I think you get a good result. And I think we ultimately did get a really good result. Ultimately, we switched back. Again, this patient didn't have significant CKD, so we were able to take some good final pictures. And I think it's a really important step. I know it's not the topic of our conversation today, but this is a young patient denied by surgery. I think she deserves complete revascularization. Her EF was already down. So when I took the Impella out, I had a little bit of contrast room. And so I took a dual lumen picture just to get a little bit of planning for her RCA CTO. So just to conclude this case, I think it really highlights what is contemporary PCI. We talked about the hemodynamics and the need for hemodynamic support. I personally was really weary of putting it in, but I was happy that I did it. And we talked a lot about that in the case. The patient became dependent on the device and basically lost pulsatility numerous times. We were able to achieve our objective pretty well. We used the 2-stent technique because it was a complex bifurcation. And we know from the Definition 2 trial that was associated with improved outcomes. Image-guided PCI has been associated with improved outcomes. And then in a randomized control trial, DK Crush beat both provisional as well as Gulat stenting in these kinds of lesions. So I think in a young patient, when we had the time to be able to do all of those steps, one by one, I think we got a really good result. And then, she'll be scheduled for an RCA CTO for complete revascularization. So this is what we did. I'm really interested to hear what others would do in this scenario. Thank you so much for giving me the time. I'm going to stop sharing my screen and open it back up to Perwaiz and the rest of the team.
Barbara, that's a great case. I think a great result and a great outcome. And I totally agree with your strategy, hemodynamic assessment of the patient. And I think that, this is the kind of case in a young patient with at need for atherectomy and essentially a last remaining vessel since the RCA is closed. This is the kind of patient that would go south. And I think you proved it, with needing the hemodynamic support for the case. And I think that was very, very well done. We've had some comments on the chat here, and I think one of our colleague Gautam's comment is probably what many of us are probably going to ask you. You with all your experience with Impella, any particular reason you didn't choose to go single access instead of doing a dual access case? Just out of curiosity.
Yeah, well, actually, the patient already had, I think, art line or something in one of the other accesses because we had to switch out her balloon pump from one side to the other. And so I already had it. And so that's why I used it. Fair enough.
It won't make it easier for yourself. Agreed.
Yeah, I think you could have done this case 7. I don't, You can't use the single access with 8 French, as you know, but we could have easily done this case as a 7 French. And if I had a radial, I would have just gone radial 7 French as well. But.
Right, and I think that's an important point. I think one of the beauties of DK Crush, and for that matter, a 1.75 burr, you probably can do it even in a 6 French system. You don't even need to go past 6 French, but I totally agree with you. It's always nice to have a little bit of comfort, and those of us, who like doing complex cases, like a little extra comfort in case things don't go quite the right way. But I totally agree. A great case, great outcome. And I think that, looking at the anatomy from my personal opinion, and I'm curious to hear what other people have to say, I think your strategy was dead on. I think the one, and you highlighted the reality of that very steep angulated circumflex bifurcation case. When there isn't as much of an angle, it's a little bit simpler to rewire and get balloons and stents across that double crushed stent struts. I think when it becomes, even with the double kiss technique, I think with that severe angle, even when you anchor exactly what I would do too, it can be really tricky to get really, non-compliant NC balloons through those stent struts. And I think you highlighted it very well. So it's something to consider. And when you're choosing a technique, the angulation is obviously a very important piece of the bifurcation. And I think you highlighted it very well. Tanveer, Gautam, anyone else on the panel
Perwaiz, do you want to address the other questions from the Q&A from our audience? So that
yes.
So just take it one by one.
Sure. So one of the questions we have here is that the question is from one of the attendees is, the proximal side optimization already described in the literature before the crush. What if you had done the proximal side optimization prior to the crush? Would that have made any difference?
So I did do the proximal side optimization before. So I did it with just the stent balloon and going up to high pressure. And as I mentioned, I think, when I'm a little bit worried about optimizing that stent, I would have swapped out for an NC balloon. But I fully believe before you do the crush, you did actually optimize the stent, because it's just, you've already have easy access to it. So even though it does take a little bit of time to actually get to it, and you're doing an extra step potentially, you're doing it to really get great outcomes. And so I personally believe that you should try to optimize things basically step by step as you go. So I hope I answered that okay.
Yeah, no, absolutely.
Perwaiz, I think in the interest of time, just very quickly go to the next two ones about the atherectomy and the whether you do the CTO first and so
right. Yeah. So the two. So I think this is always a debate and a good conversation topic. We'll keep it short and sweet to the point. Any consideration of doing the CTO of the RCA first, prior to fixing the left main, to give you a little bit of coronary perfusion backup, as we like to call it?
Yeah, I think that's always a reasonable step. And in this case, I actually wired antegrade with the RCA, and I used the Mongo, and it wouldn't go. So I was done with doing that. I tried to actually just do it right at the end of the case, but so this case kind of proves that I'm probably going to have to go retrograde to be able to open up the RCA. There's good channels to be able to hopefully do that. So I think that took that out of consideration. And personally, I think it just depends on the skill of the operator and then the case hemodynamics case by case. In this case, I probably wouldn't have mucked around too much with the CTO unless if it was pretty straightforward without doing that left main first. Because otherwise, if a patient starts going down or you get some complications or become ischemic, you have very little reserve.
Okay, let's stop here, Perwaiz, and go on to your case in the interest of time. And if it's time at the end, we can come back to these questions. Okay. Sure. So now Perwaiz Meraj from Northwell will present his case. Perwaiz is a high volume, nationally recognized operator, and Basir will be the discussant. So Perwaiz, go on, share your case and get going. Thank you.
No problem. Thank you, Tanveer, and thank you for the opportunity to be part of this amazing club. It's as Babar said, in the first meeting we learned so much from all of our co-panelists and co-members of the Bifurcation Club. Hopefully, this is an interesting interesting case, and trust me, for those of you who are out there, Babar and I did not plan this. So this is a totally different strategy, different thought process, and I'm curious to see what people have to say. So the topic, one stent or two is always the question in bifurcations. So let's see how that plays out. These are my disclosures. Nothing really pertinent to bifurcation PCI. So just as a quick case presentation, 64-year-old gentleman with known ischemic cardiomyopathy with an EF of 23%, status post PCI. He had an large anterior wall MI, and he didn't recover his EF completely. He had an ICD placed, and more recently, he's developed very multiple ICD shocks or VTVF from his defibrillator. He's having ischemic symptoms with minimal exertion, which he was not having previously. He's on optimal medical therapy, and he has a known history of a CTO of the RCA, which was never revascularized. So we decided to plan the referring physician send him in for an urgent cardiac cath. And so just to quickly review, just to show you the CTO of the RCA, we were under the impression initially that this was probably the culprit, and so we went ahead and opposite to what you guys did, we went ahead and did the CTO of the RCA first, and we went ahead and fixed it. Since this is not a CTO conversation, we're not going to go through all the details of this, but we were able to do integrated wire escalation, and we were able to open up the RCA CTO, and everything went well. You can see here, there was not an impella in the first shot, and there was an impella by the end of the case. And it didn't take very long. And the one thing that hemodynamically we didn't anticipate this happening, but upon the injection of the left main coronary system for retrograde imaging, the patient would drop his pressure. We did it twice, and every time we gave him contrast, his pressure would drop into the 70s, systolic. At which point we realized that he's extraordinarily sensitive to getting just contrast. If we make him any which ischemic with a retrograde catheter, this would not work. So we placed the impella immediately and proceeded to finish the CTO of the RCA. At the end of the CTO of the RCA, we stopped the case and we said, you know what, I think we're good. Let's see how he feels. And like I mentioned, he had contrast ischemia, but after the case and within a week, he had recurrent symptoms and recurrent VTVF. We're like, okay, maybe there was something more to that left main LED. So we said, let's bring him back and let's reassess the left main LED and circumflex. So let's show you. We just reach out the right coronary to make sure that we didn't miss anything. And then here's a picture of the distal left main, proximal LED, and the proximal circumflex. And you can see here, it's a 111 lesion. There are stents, prior stents, as I mentioned earlier, in the LED that's jacketed the entire pretty much LED from the ostium all the way down to the mid to distal LED. The circumflex was not stented. And we decided to do an ischemic evaluation at that time, and we saw an IFR from the left main to the LED of 0.65 and the left main to the circumflex of 0.80. And we can obviously have a conversation about utilization of IFR to determine the left main ischemia versus imaging. But this is where we stand. So having said this, without going any further, Babar and my elite panelists, what would your take be? You have a left main ischemic patient, the lesions are real, there's stents into the ostium of the LED. So knowing all this information, what would your strategy be?
Yeah, I think it goes back to you did all of the things that I would have done as well. You've already physiologically demonstrated that this patient's going to have significant ischemia or has a significant ischemia. And so now what I think you're left with is basically my strategy would be you have space to wire and now you space to image both of these. So I think you kind of want to see how that first stent was placed and how optimized it was, and then kind of make a decision from there. That's how I think I would start.
I think if you play the movie slowly, there appears to be a tight ring-like lesion or disconnect right at the ostium of the circ.
Yes, there is definitely a very tight lesion right at the ostium of the circ. Absolutely correct. And the question, exactly what Babar is bringing up, is exactly what does that LED stent look like? One, and exactly where is it with respect to the ostium of the LED? Because angiographically, it appears like it's at the ostium of the LED, but is it really at the ostium of the LED? So, to your point, that's exactly what we did. So before we did anything, we ended up putting an IVUS catheter down the circumflex and to see where was that LED stent. And if you see here, and I purposely kept this as and I'm going to try to freeze it here, so bear with me. You can see right there, and this was, I hope you guys see my mouse pointer, but you can see here, that is the LED stent, clearly suboptimally expanded and sized, and this is your ostium of the circumflex. So the stent in the LED does appear to come all the way back to the ostium, to the distal left main bifurcation. Impressively so. I wasn't expecting it to be that good, but it was sitting right there, which makes it a more interesting case into how you deal with this. But you can also notice, and I didn't for the sake of time didn't put the IVUS of the LED in here, but you can see here from even the ostium LED, you can see a lot of you can see what we call angiographic instant restenosis. However, there's not a lot of neoatherosclerosis on that stent. The stent is just undersized, and there's very little neoatherosclerosis on the stent. So the stent actually looks pretty good.
Perwaiz, how old are these stents?
This stent is probably 4 years old.
So do you think, this issue has always come up, that if you have metal struts at the ostium, it sort of permeates into the left main, it somehow incites a very aggressive, neointimal hypoplastic response. Do you agree with that, or you disagree with that?
I've had that happen. I personally see that in the circumflex more than I see that in the LED. However, in this particular case, it doesn't appear that there's a lot of neoatherosclerosis on these stents. It just appears that the stents are just very undersized and not optimally sized. And probably 4 years ago, we barely do enough imaging now. I guarantee you 4 years ago, they probably didn't image this at all when they were doing the PCI. So this particular IVUS was very unique. It's not very common that I see this kind of an IVUS image. Normally, when you have a bifurcation lesion like this, you have some space or a gap between the prox LED stent and the true ostium LED. But given this, we decided to move ahead and say we're going to use that prox LED stent as the LED stent, and we're going to do a provisional stent from the left main into the circumflex, and then come back and then do a kiss. And so this is what we did. We wired both. We went ahead and optimized the LED stent. IVUS guided sizing. We went ahead and maximally sized the LED stent to the true vessel size. It actually appropriately expanded, and we confirmed that on IVUS. We then ahead and went in from the left main into the circumflex, sized the stent there by the distal reference, did a proximal optimization of the left main into the circumflex prior to wiring back into the LED. As you'll see here, doing a kissing now maneuver. And this is what we were left with at the end angiographically. And you can see here angiographically, the stents actually connect angiographically very well. And I'll show you the IVUS image in a second to show you what happened here with the IVUS. This is the post-IVUS, and you'll see here, I did just a short run of the left main just to show you how that looks. That's the left main itself. You can see here, that's the circumflex, and you can see here two circles, essentially, as Babar said, Rich said in the last meeting. You can see here, and I'll try to freeze it to try to prove that a little bit. You can see here, this is from the LED into the circ on the bottom, and you can see, left main into the LED on the bottom, and the left main into the circumflex on the top. And you can see here, stents into both areas, well opposed, well covered, and covering all the tissue planes. So this is an interesting case, and I'm actually curious to hear what people had to say and what would you do, and would you do anything differently? I don't know if there's a right answer to this. This particular case was extraordinarily uncommon and rare. However, by the way, we did a post-IFR of both the LED, left main into the LED and into the circumflex, and both of those were also now negative. It was 0.93 and 0.95. So we removed the ischemic burden from his left main. And this is where we stand. So Babar, I'm curious to hear what you have to say.
Well, it's so hard actually, because I'll be honest with you, a 4-year-old stent, I don't know, my original thought would be to recover it, to be honest with you, all right? To use the medicines and to basically, transform that into potentially a culotte, because you're already stuck with that left main stent already there. But, I think that, the real future is going to be when we have drug-coated balloons, right? Because I think that this would have been a great example for a patient who would have gotten a lot of benefit from doing exactly what you did with the final drug-coated balloon. But really, ultimately, what we're going to find out is 2 years, 3 years from now, if that LAD does kind of restenose in that proximal segment after optimizing it after 4 years or not. But I think less metal goes a long way, right? And the patient's only 64 years old. He potentially could be a candidate for a robotic Lima to LAD if he needed it in the future as well. So I think this is a really good, safe, easy way of kind of doing the right thing. But I think the case highlights so nicely extreme importance of imaging, right? It's a great example.
Yeah. No, I agree. I think that there was no way I could have made that decision without looking at the imaging. I think that imaging is what sealed the deal for me to be able. And like I said, I don't know if I did the right thing in the end, but at least I knew that there was definitely metal there that I could work with.
I think Gautam has a question.
Hey, Perwaiz, great case. I just love the statement that you made. There was definitely metal there that I could work with. I had a case very similar recently as well. And that's your strategy is exactly what I decided to do. And, I'd like to ask the panel again, in a stent that's 3 or 4 years old, conventional 3rd generation drug-eluting stent, what do you guys think are the chances of restenosis if you expand it? Is there any data out there? Because it's going to be big, right? When you expand it with a 3.5 NC, you're talking about a MSA of 10, 11 kind of thing. Now, what do you guys think is the chances of restenosis in a stent that's that big?
I don't know of any data to say what that number is. I agree with you. We all think that it would be relatively low being able to do that. But optimizing a stent 4 years later, I personally, have a little bit of caution with it. But again, I think all of us are saying we would probably do the same thing and kind of not put in more metal.
Yeah, I agree. I don't think we know the answer to that. I mean, anecdotally, we've all seen cases of 4 millimeter stents having severe restenosis, which is a case by case scenario, but from a large case series or a randomized study to give us that data, I don't think that data really is robust.
If it's not this area, I think you may have put on a stent, but you clearly should shy away from putting more metal at that bifurcation. That's the
correct. And I think this highlights a question that I don't think, and again, I don't think this is a data-free zone too. We all know more metal is bad, but we really don't know in this particular scenario, would more metal be better in a few years for restenosis or not? And, anecdotally, my experience in doing these kinds of cases is that the less you do, the less metal you put in this area, the better it ends up being. You just get yourself into more trouble. And so that's why I did it. But again, I have no way of proving that to be correct.
But thank you,
one quick question. What if you had a little bit more of a gap in between that stent? I mean, because, let's say it was 3-4 millimeters of a gap. I personally probably would have still left it.
You bring up a good point. I think I would have left it depending on what the imaging showed, right? I think this is what it would have been. I think had you seen a ton of plaque or a dissection after you ballooned it or something like that, that would have really, and I think, with people that have this much disease, you tend to see, even with 3 or 4 millimeters, you'll see something that just doesn't sit right with you, and especially, maybe angiographically it doesn't look so horrible, but you image it all of a sudden, you're like, oof, I can't leave that alone, so that's what ends up happening. So it's a catch-22. Every case is so unique.
So guys, should we go ahead with our guest then? So our guest is Sunay Shah from Florida, and thank you, Sunay. You submit an interesting case, and both Babar and Perwaiz will be the discussants. Thank you very much.
All right, thank you very much, Tanveer. My name is Sunay Shah, and I work in Memorial Regional Hospital in Hollywood, Florida. And the case I'm going to show to you today is called double DK crush. So briefly, it's a 55-year-old gentleman, history of multiple PCIs in the past, and he was presenting with a non-STEMI. Troponin peaked at 0.29, and he has a normal EF. EKG shows some lateral changes on the EKG, and this is what his angiogram showed. I'll pause it. So on the angiogram, he has stents in the LED. He has a stent in the native circ in the mid portion. There's an angiographically severe lesion here and an angiographically severe lesion in the native circ, and the native circ is retroflexed. IFR from the left main into the LED was 0.95. IFR into this large obtuse marginal is 0.71. And you can see on the IFR pullback, all of that gradient is coming from the ostium of this left circumflex. I did try to send the IFR wire into the native circumflex, but because of the retroflexed anatomy, I just couldn't pass the wire there. So I guess maybe I'll take a quick pause. By the way, I did this case within my first year out of fellowship. So this was, I think, 9 months out of fellowship, and I encountered this case. So I did pause and I talked to my senior partners about how to approach this osteal circ lesion. I guess maybe I'll ask the panelist how you would approach this case before I go into what I did.
I think it's a really interesting case, Sunay. It's difficult. I think even if you were able to successfully wire into that true AV circ, I don't know what the value of that IFR potentially would be, just because of the wire bias as well, potentially. I'll be honest with you, when I look at it here, I would probably image from the left main into the LAD. I personally think, without, that it'll look fine. I don't think you'll get away with, hitting the ostium exactly. So I think you have to probably at least take the patient off the table and talk to them about a stent going back into the left main. I personally would probably just stent directly into the AV circ. I found that gives you a lot less bias, and then balloon into the OM. But your title already gave away what you did. So. Perwaiz, any comments?
Yeah, no, I agree. I think that the territory that you're looking to try to salvage and save, and the technique that you're going to use is key. And I think that, I agree with Babar. I think if you're trying to salvage both territories, you send into the surf and balloons the OM, and I think that would be the smartest, safest way to do that if you were not planning on doing two-stent strategy here. But I'm curious to see what you ended up doing and how you ended up doing it. The left main is tricky. To land this perfectly without getting into the left main is a very, very, very tricky scenario.
Yes.
Today, one quick question.
Yes.
What did you tell the patient was the risk of this thing coming back, or restenosis risk? What are your thoughts on that?
Yeah, we did talk about that. I did tell him that probably the native circumflex, anything we did to this based on the just the anatomy of this, the chances of this staying open long-term is pretty low. But I did think going into this large obtuse marginal, the chances would be pretty reasonable. And I did tell him surgery was not really a good option for this, just because the LED is fine right now. So that's what I told him in advance of the procedure. The technique I went for, and I quickly realized when I started putting the wires in, everything straightened out, and trying to land things perfectly would have been impossible to land it perfectly at the ostium without having the stent extend into the left main. And usually if you're going to go for that osteal circ, you'd rather be a little bit into the left main than short for restenosis purposes. And I didn't think that was going to be possible to do properly. So I tried to keep it as simple as possible. And then as I was working, it just got more and more difficult. So I ended up doing something where I stented from the native circ into the large obtuse marginal with the DK crush. And then I did also another DK crush between the circumflex and the left main. I did image both the circumflex and the left main prior to doing anything. There was a significant plaque burden in the distal left main. It wasn't terrible, but there definitely was plaque in the distal left main. I did use a 7 French guide and an EBU 4.0 guide from the right radial axis, and no plan for mechanical support. Normally have seemed like pretty straightforward lesions in terms of plaque and not too much calcium. So here's how I started. I ended up triple wiring. I sent a sport wire down the LED, cyan blue into this large OM, and I sent a pro water to the native circ. Making this bend into the native circ was extremely challenging. I used a Supercross microcatheter, 120-degree angle. It's the first time I ever used it, and it was a lifesaver for the procedure because I could never wire this vessel. It took a very long time to wire this every time. First step is I placed a Resolute stent, 225 by 12 in the native circ. I had a balloon ready to go in the OM1, And after I inflated the stent, then I would crush it right away. I would pull the wire out and then I would rewire it, which was every time rewiring this native circ always took a few minutes. Once I would get rewired, I would do my first kiss into the native circ. Once I did that, I pulled out the wire from the native circ, the pro water, and focused on the OM1. Now I have a Resolute 275 millimeter into the OM1, and I have a 3.5 NC balloon in the LED. After the this stent had a few millimeters extending into the left main, and after the stent is inflated, I then crushed it with a 3.5 millimeter balloon in the left main. At that point, I then pulled the wire from the OM1 and rewired it and performed my first kiss now in the left main to the native circ, or sorry, the circ into the OM1. Once I did the first kiss here, then I brought my microcatheter back in and I rewired the native circ again. And I performed my second kiss now. This is now a 2.5 millimeter balloon into the OM1 and a 2.25 millimeter going into the native circ. That then allowed me to finish this bifurcation between the OM1 and native circ. And then I landed a stent from the left main into the, just to overlap into the prior LED stent. And then I rewired the OM1, performed my second kiss now between the left main and OM1. And prior to getting to the final pictures, I did proximal optimization of the left main with a 4.5 millimeter alone. This is what I ended up with at the end of the case. And I didn't share my IVUS images with you, but overall by IVUS, I kind of got the same results that you showed on prior cases with the stents having the circles from between the two bifurcations. I was unable to IVUS into this vessel though at the end.
Yeah, ultimately, it looks like a great result, Sunay. I mean, it's a hard case to do 9 months out of fellowship for sure. You know, it's a lot of complexity in that decision-making process. You know, I think, you know, ultimately, if you got a great result angiographically, that goes a long way. Clearly, it's a lot of metal in that ostium of the circumflex, which is always my greatest worry about ISR. But hopefully you keep track of this patient and let us know on an angiogram a couple of years from now how things look. And I think that's going to be the testament of the strategy used. So, but congratulations.
Yeah, so just a follow-up. So I did this case 2 years ago. The patient at the time of the case was actually on disability. And 2 weeks after the case, he went back to normal and went back to work, and he's been working since. Angiographically, he did have a catheterization done. I did it a few months ago. And sure enough, right in the ostium of the native circ right here, there is some restenosis, but this bifurcation has remained, looks beautiful.
Nice.
Did you have to do, did you angioplasty that ostium of the circ again, or?
No, I left it alone. Yeah.
It's probably smart. We'll tell you it's probably better to leave that alone. No, I agree. I think that, you know, whenever you have that much metal in that proximal circ, I get scared too. You know, it's you know, the one all of us can say the same thing. I'm sure we all had the same experience. It's been published, you know, numerous times in previous, you know, studies. You know, when you do these bifurcation cases, and that's why DK Crush has probably been so successful in the strategy for a left main LED bifurcation, is that the issue with that proximal ostial circ restenosis and not really being able to appropriately cover metal or drug and the struts you go back through, you know, like exactly what Bobber, you know, went through very beautifully in this case description. It's so key to do those steps, because if you don't, that's the kicker. You know, that proximal circ really just gets you in trouble after time. So nicely done.
So Muhammad is one of our viewers. And so Mohammed, thanks for your question here. So you said great results. I think the twin pass microcatheter would have helped too. I think that that's a very good strategy as well. I think a supercross, if you're going to use it, the 120 is really helpful because it really does give you that big bend. Otherwise, what ends up happening is as soon as you put a wire in, it ends up straightening out whatever curve. So the shorter bends, the 30 and 90s, tend not to work as well. But yeah, a twin pass microcatheter wiring into the OM and using that second wire to get into that AV circ would have also been a good option.
And Barbara, we also have a question in the Q&A section that's asking, typically the AV groove circumflex is never grafted by the surgeon. Would you have considered a POBA only to that actual AV groove circ? And then obviously the point was brought up that using drug-eluting balloons to the circ OM and only if there's any dissection, which in the United States is an issue, obviously, since we don't really have on-label use of drug-eluting balloons, though I'm sure all of us have used peripheral drug-eluting balloons in the coronary. It's off-label, but that's not on-label.
Yeah, unfortunately, they're only 4.0 by 40.
Yes, they are. That's true.
You're usually not using them in a case like this, but Azam's not on today, but it would have been great to ask the European experience on this. But it's surprising that we're still so late, probably because of the FDA data that came out on the peripheral mortality trend that was it's still being a little bit disputed now. But I think when drug-coated balloons come in, a lot of these lesions can be treated provisionally with a drug-coated balloon in the side branch.
Agreed. There's one more question that came up. Any consideration of routinely using cilostazol to avoid restenosis in patients who have more than one layer of stents? Bobber, what's your take on this?
Yeah, I looked into this a lot. So Bill O'Neill actually was kind of thought about this years ago. This was 7-8 years ago, and we used it on a few patients. So first of all, the side effect profile is real. These patients can get, I think it was oral ulcers and kind of dermatological problems as well. And to be honest with you, the data really hasn't panned out. And I can tell you anecdotally, for those cases that we did with severe ISR, refractory to brachytherapy and multiple interventions, we actually never got a good result. I honestly think in those cases, the best friend is a surgeon if possible. Yeah,
I agree. I think that's a key piece of key point. I actually did a case today that pretty much exhibits that exact scenario. I've had so much ISR in this particular patient, but the previous operator who stented him pretty much took away his surgical option by stenting everywhere that a surgeon would bypass. So unfortunately, the surgeon's not his friend. It's going to be my problem for a long time to come. But I don't think cilostazol hasn't really panned out. We've tried it as well. We haven't seen too many side effects from it, but albeit it has been reported, but we just haven't seen any beneficial effects of it. That's for sure for ISR. So
there's one question from Barbara's presentation: the use of rotational atherectomy in a angulated bend. In your case, Barbara, do you have any comments on that?
Yeah, so my personal practice is really kind of 50-50 as regards to rotational and orbital atherectomy. I've personally seen a few orbital cases in severe angulations kind of shear off, at the point of the burr. And so, I tend not to use that as the more angulated it is, the more I like rotational atherectomy is my own personal bias. But that being said, the advantage of orbital atherectomy is you can cut on the way in as well as on the way out. And so, that's my strategy. What about yours, Perwaiz?
Yeah, no, I agree. I'm probably about the same, 50-50. I'll tend to use orbital actually quite a bit in left main bifurcation cases. Again, imaging guided atherectomy will show you, like you showed, a true fracture of the calcium. I feel like in the larger the vessel, orbital tends to fracture calcium a little bit better. When it's more nodular or when it's more like focal in a corner, again, orbital probably fractures it a little bit better. But I agree, I think I personally don't like to compare the two and you say one versus the other. I think, you know, those of us who do complex PCI need to know how to do both and use them where you think it's best. But you're absolutely right. I think that is the advantage of being able to go backwards with orbital, but rotational atherectomy clearly worked great in your case, and it works great in most cases.
Well, and the advantage of orbital is that you can actually do large vessels with the, you know, the same size. So I have a similar feeling, is that you do it all for one, and then you can really, I think if you have a vessel that's greater than 3.5, going on high speed for at least one run is really important if you really want to get a good result.
I agree.
Not to forget, you know, IVL is going to be released, I hope, early part of next year, and probably will be very important, you know, plaque modification, you know, putting in osteocirc side branches. I think Gautam raised his hand again. Gautam, do you have a comment? Okay.
Yeah, I just wanted to echo the comments by Perwaiz and Mayor Basir that you know, it's been my experience as well with complex PCI and doing both orbital and rotational. I just find that the other mechanism with orbital is that you get some fracturing of the medial calcium as well, especially in cases where, you know, you may have you know, both superficial and deep calcium, and that fracturing of the medial calcium can probably help contribute to some of the larger MSAs that you get. And we've seen that in some of our IVUS cases as well. So it's actually pretty interesting. But yeah, you got to be facile with both techniques.
Yeah.
So any final comments, Perwaiz and Barbara and Sunay? Any final comments before I close this meeting?
No, thank you so much for organizing this again. It's really fantastic to learn from Perwaiz and Sunay and the rest of the panelists. It's been a pleasure.
I think Babar's being very humble. I think we all learned from him today, as well as everybody else. And I think that it's a great forum to present cases and talk amongst ourselves. And you know, there are probably many ways to skin a cat, as they say. It's best to learn all of them, and so we can all learn from each other. So thank you, Tanveer. So
thank you, Sunay, for presenting an excellent case. Our next session will be December 16th, where the presenters and discussants will be Gautam, Kumar, and Kevin Crows from Brigham and Women's, and hopefully you all can join us. Final thoughts are for these cases are putting in Bauer's case, hemodynamics are very important. Putting in somebody with a low EF and complex PCI. Imaging is king. I don't think you can do any of these cases without optimal imaging. I think those days are gone just to look at an angiogram and do this case. I think from Perwaiz's case, we learned not to add more metal to the ostium of the LED. And I'm not sure what exact technique it was, but it could be a modification of Coulomb, but it is some technique, but it worked very well. I think the other thing is that there's some merit in patients with low EF, and this was just published recently, that patients with low EF should really have mechanical support while these cases are done. From Sunay's case, I think there could be other options, particularly if shockwave came around to treat the osteocirc before stenting. Certainly, if drug-coated balloon comes around, you may not have to worry about the continuation of the circumflex. So we're all learning from each other. I think we all have great tools, and I think as we continue with these case presentations, we'll learn a lot more. And to the audience, thank you very much for joining, and please join us again on December 16th, and we'll send this out again, our program, to social media and emails as we have done through C3. And thank you for Mia and Elisa, and also Raj Dave for organizing this, and allowing American Bifurcation Club to really be prolific very early on with great operators and people willing to share the cases. And thank you very much, and have a good evening. Happy Thanksgiving.
All right, thank you so much.